please just flag to me or ask a question at the end. So, digital health. What do we mean when we talk about health technology? This is actually one of the most complicated things to describe to people, and I appreciate that this is quite a busy slide, so I do apologize for that. We see a lot of chat about e-health, m-health, people talk about AI, they talk about robotics, and then virtual reality. These tend to be the kind of big buzzwords that are thrown around, and often we don't really get down into the nitty-gritty of what they all mean. For the most part, not that it doesn't matter, they all broadly come under this umbrella of health technology, but I just thought it could be quite useful just to let you guys know, both so you know what I'm talking about, as well as to have a think about yourselves whether or not you agree or disagree with these definitions, which are broadly taken from the World Health Organization, as well as some other groups like NHSX here in the UK. So e-health is our kind of information communication technologies, the best examples of those being things like electronic health records and telemedicine. M-health is your wearables, your Apple Watches or smartwatches, things like that, as well as using things like phones and other sort of smart devices to have this kind of wireless communication, virtual monitoring. You've got artificial intelligence, which again comes under lots of different definitions, but broadly is the creation, use of algorithms, software, the sort of copy what humans are able to do, quite literally artificial intelligence, and they can be involved in lots of different interpretation, comprehension of health and healthcare data. Robotics, again, seems quite obvious, but it's the use of these intelligent machines to help and assist humans to deliver healthcare and also research. And virtual reality, which is one that I think we don't talk about a huge amount in medicine yet, and is very much a quite cutting edge and emerging field in therapeutics. And that sort of use of computer generated simulation of like a 3D environment that allows users to interact with it. And this is being used for lots of different therapies, both psychological as well as along innovation in medical education. So what can this achieve? What are the kind of exciting things that we're able to do with all of these fancy technologies? So like I said, I could talk about this for hours, so I've just kind of brought up a few key highlights. So we've got AI-powered disease management. AI has been used to detect the presence of cancer in medical images. We're using facial recognition technology to detect rare diseases and what previously would have taken often years of diagnosis, going through lots of genetic material. Improve mental health diagnosis by analysing patterns of speech, and also kind of tailored interventions for everything from drug management to cognitive behavioural therapy. Like I was saying, we can do remote monitoring with wearable technology, which allows us to much better look at someone's disease management, how they're getting on, biometric data like their heart rate and their oxygen levels, saturations, things like that, as well as allow us to gather this information to predict future health risk. And that's a big thing that my team are working on in the UK, and I know is happening in lots of other countries, this idea of predictive prevention. So gathering all this real life information and using it to try and predict people's risk of illness and intervene. Healthcare assistants, like this is quite an interesting one. So there's people doing all sorts of things, be it delivering medicines on wards, to also working in laboratories to expedite medical research and allow much more to be done at scale. We've also got virtual reality therapy, which I was touched on earlier. So for example, there's some really cool innovations at the minute for people that have got phobias or obsessive compulsive disorder, where we use virtual reality to put them in an environment and help them overcome that fear. And it's actually so far been found to be really effective beyond what we were kind of expecting. Surgical robotics is one of the big use for robotics. There's lots of really cool things going on. Not always it's very rare that you'd be allowing a robot to go and perform a full procedure, but there's actually lots of trials going on to show that they can start to do quite minor procedures, as well as assisting in things within theatres, be that like holding back retractors, or able to get into quite small spaces that human couldn't. And some of the cutting edge technology at the minute, which is really interesting, is they're basically trying to teach these robots to react in the same way that hands would, so that they won't need human intervention to operate. And precision medicine is another really big area, and this is kind of bringing together genomics and big data to again allow us to personalize treatment regimens and clinical care. So that all sounds super overwhelming. I completely appreciate lots of exciting things, lots of buzzwords going on there. Really the big thing for me about what we can achieve with health technology is, yes, reduce burden by understanding people's health risk, improving the diagnosis and treatment, making our health system more efficient, and hopefully better connection between doctor and patient. The thinking being is that we've gone over the last 10, 20 years into these tiny consultations that often only last 10 minutes or sometimes even less, and that we've got people, doctors and nurses are seeing more and more patients than they ever would have had to before, and that by using technology we can actually augment their practice, allow them to focus more on that human connection that they have with their patient, rather than constantly being focused on taking histories or getting information or analyzing information. So who's going to benefit? Well, there's been obviously huge growth in health technology over the last, I think, 10 years in particular, but you could arguably go right back for several decades. This is quite an interesting study looking, this actually the World Health Organization did here on the left, looking at the growth of national health records over the past 15 years, and this came out in 2015 data, showing a huge increase, particularly in upper middle income countries, but again showing that there's a disparity. And although we don't have very good data over the last few years, we can see that yes, we have seen a growth of electronic health records, but actually they've been sort of staying along those same lines. And again, this is from 2017, this map, but it's just showing 35% of countries that we could get data on had a health technology national policy that's part of the national health program, with another 12% having an independent, e-health or health technology strategy. So just showing that exponential growth, and that actually it's found all over the world, although there are obviously some real hot pockets, particularly Estonia, as Priit will come to. So we're also looking at how connected people are. The Ericsson mobility report is a really, really good report for this. I do appreciate it comes from a private company, but I have to say I've used it for years to be tracking internet connectivity, and it's always been exceptionally good. And this is just to show how the increase in mobile subscriptions, broadband subscriptions is happening, what the prediction is by 2025 of just how many people in the world we're expecting to be connected, and seeing huge growth across Asia, particularly China, and right across the African continent in particular. So the thought being is that over 2/3 of the world's population would, in theory, be able to access a lot of this health tech innovation right in their own pocket by 2025. Obviously, there's lots of mitigating factors in there, but there still obviously exists this idea of a digital divide. And this digital divide exists for lots of reasons. Of course, the sort of access to hardware, to technology. Not everyone can get a device, a computer, phone. The internet's best viewed, I think, is more like a spectrum rather than viewing it as a binary. Yes, I can access, yes, I can't. Because although there's lots of statistics that are lauded around of how much of certain countries, certain parts of the world are able to access the internet, and that doesn't always mean that they have very good access. It doesn't mean that they can access it at all times. It doesn't mean that they can, although you can say someone can access it based on where they live, it might be they can only afford to have so much of that, or that the quality of it is so bad that they're only able to access certain parts of the internet. So shouldn't just be thinking of this have and have not. It should be sort of all viewed as a spectrum. And again, this idea of digital skills. So globally, there's a link between increased age and reduced education leading to lower digital skills. However, the best data on this of studies that have been done mostly comes from Europe and the USA. So again, although we're seeing this huge growth in health technology, we're seeing more people getting connected, there's still this huge digital divide that mean that not only do we need to work to bring more people into technology, but also need to appreciate that whenever we're designing services or health systems, that we're not excluding people purely because they're not able to access. So I just wanted to touch a little bit on some of the stuff we've seen in response to COVID-19. I'm sure lots of you have been up to date on this. You'll have seen lots of this discussion on the news, and I think certainly been a really exciting time for me and lots of people like me who work in this kind of ethics and regulation space. This idea of how we do innovation in this unprecedented, as they like to say in the UK, time. So the role of technology in pandemic response, there's obviously lots of different things it can do. The kind of key ones being, or the key one being epidemiological modeling. So this is mapping of a disease spread, looking at the disease course to inform your public health response. There's lots of different ways we can get data, and I think that's been one of the really interesting things that we've seen. Actually, a lot of this learning, I should say, right, Roshia said right at the start, a lot of the learnings actually come from Ebola, and that's been one of the most amazing things is the few Ebola outbreaks over the last several years have actually taught us so much about the use of technology in this space. And I think, yes, we've seen lots of really interesting stuff happen in COVID, but a lot of that is built on work that was already done. I really think we need to make sure that we're not forgetting that and thinking that COVID has been this big transformation when a lot of this was already being used and a lot of this innovation already existed. So epidemiological modeling, we can get data from lots of places. So you've got your health system data, obviously everything coming out of hospitals, testing facilities, individual data. And this has been really interesting during COVID-19 is lots of people creating self-reported sort of symptom apps When we've got a big one in the UK. I know the WHO is creating one, which is, and as well as contact tracing one that's going to go across a number of different countries. I'm also using social media data, and this is really, really interesting for lots of reasons. And one thing that I was working on quite recently was we were trying to see what people were talking about on Twitter. We were literally just pulling information based on hashtags, based on location, to try and see, like, yes, we're putting information out there as a public health agency, but what are people saying about it? How are they understanding it? As well as also sometimes using social media as a proxy for location data to sort of see how people are moving around a population. See, you know, a lot of people putting up pictures of them out in the countryside, despite the fact they're supposed to be in lockdown. So that's been really interesting, and really interesting part of adding to these models, which are getting more and more complex, more extensive. Also, research and innovation. As I'm sure lots of you see, and particularly during COVID, there's been lots of chat about different drug treatments, different drug regimens, how they're going to work together. So there's lots of different clinical trials going on, as well as just smaller groups in hospitals testing new things, understandably a bit desperate at times to try and curb this and curb illness. And what algorithms have been quite useful for, and there's been really, really great work done in Singapore in particular. They create this whole big, very pioneering platform. It's to sort of increase the efficiency of gathering all this information together, allowing people to just plug in the response of their patients to different drug regimens, the different molecules and things, and we're able to then just do much, much deeper analysis of this at hugely increased pace. And also delivery of health information. Again, this has been a big issue, certainly in some of the countries I've been working with recently, with the digital divide, is who's not getting information because we're relying potentially too much on technology for it. But it's also been really useful, not just for getting information to the public, but getting information to healthcare workers. And there's a great example of this was the M-Hero app was created in Liberia, which is used to send in like a purely SMS based, which is what was really interesting. People thought, you know, we need lots of fancy apps which would connect frontline workers and governments, sort of strengthen the health information system, and also provide those critical alerts in a way that they were going to see. You know, people are going to see a text in their pocket, they're maybe not going to be logging on to an email or to a computer system to get that. So being able to be agile in that way and use technology to get information out very fast, and hopefully that you can check its accuracy, has been really important. So some of the big things that you might have seen, really touching a couple of them, is, one huge increase in telemedicine. This has been amazing, particularly in lots of countries that were quite resistant to it, lots of clinicians quite resistant to it, all of a sudden haven't had a choice and seen the huge benefit of it, realize it can work for them. And this has been really interesting, as well as innovation in telemedicine itself. All of a sudden we're seeing people creating technology that can assess someone's oxygen saturations purely based on a video image. Now, I'm not saying this is perfect, and there's lots of issues with it, particularly around who it will and won't work for, but it's been really interesting to see that kind of innovation get lots of support. Contact tracing apps are huge, maybe something we should leave for the discussion, but again, you'll see lots of chat about how we use technology to be able to track cases, track them in real time, let people know again quite quickly that they potentially are at risk of having been in contact. But again, this obviously comes with lots of discussion around privacy and also efficacy. And like I said, WHO is creating one that's been very interesting to follow along, and I'd recommend you keep looking for updates, because what they're creating is not only going to be one that's going to have to work across lots of different cultures, but will also work across geographical boundaries, which is really important, because there's no point if I have an app that works here in the UK if then I go to, you know, France or Ireland and all of a sudden it's not able to work there or function there. We've also seen lots of innovation around medical education. This is again a little bit of a plug I don't work for the WHO, I should say, a little bit of a plug for the WHO Academy app, which I think genuinely is really clever. What they're basically doing is sharing critical evidence-based information and tools to healthcare workers across the globe to help them improve their skills and capabilities. It's really important because there's so much information coming out, so much going on, to try and again get this information to people and from a source that they can trust. And coordination of resources obviously has been massive. A really great example of this has come from Kenya, which is a team of startups who I think important. The reason for highlighting this one in particular is these weren't all health startups. They came from e-commerce and lots of other different micro distribution platforms, and created it was called Safe Hands, to deploy soap, hand sanitizers, cleaners, disinfectants, masks through hundreds and hundreds of thousand distribution points. Like, it's honestly absolutely incredible what they've been able to do. And I think, again, it's just showed the importance of leveraging all different types of technology in the health setting. But there's also been some negatives, which we've, again, slightly touched on. One thing that I'm quite concerned about in the UK, and I know this is happening in other countries, and I'm just using the UK example because I know it the best, which is that we're all of a sudden, we're creating these public-private partnerships that could potentially cause harm, that we are giving lots of personal data over to to massive companies, and that yes, this is important, they're doing potentially quite good work for a pandemic response, but what kind of dependency is that going to create? How are we going to disentangle that after? Lots of issues with fake news and conspiracy theories going on, spreading of disinformation, be it from ineffective treatments, to also then causing some, in quite intense ways, attacks on individuals across race, class, religion, etc., as people are being scapegoated and blamed, and things going on. There's also been a huge funding fall for a lot of startups, and I know that as someone who usually works with a lot of startups, I'm seeing a lot of that work not going on, which is actually very important to just keep in mind, because what we're going to see is that small scale grassroots innovation is not able to grow, and we could potentially just see bigger and bigger monopolies to the Amazons and the Googles of the world, who will have the financial reserves to get through this. So what do we do to balance this? Again, we could talk about this forever. I think one really important thing to caveat is we talk a lot in technology, or in health technology, about ethics and what that looks like. And I think this is a really complicated space, because yes, we have got, you know, medical ethics and biomedical ethics, and there's like lots of things that lots of us would agree on, but actually whose ethical standards, whose morals, whose sort of frameworks we're using is quite a big point of discussion, and what's going to work in one country or region isn't going to work for others. But there are a few sort of core principles that certainly we here in the UK, and again working with mostly European partners, but also a few in Rwanda, Kenya and Nigeria, have been sort of discussing about how we come up with this kind of model of what good governance or good regulation would look like. So the sort of key principles we talk about are something being user-centered. So it should actually really address a need within healthcare. It shouldn't just be, you know, to make money. Designed for users' needs, both accessibility and their cultural context. That it should be safe. Now again, that seems quite obvious, but you'd be surprised what goes on. So having high safety and security standards that allow people to feel safe and engaging, and also sanctions in place for people that break those. They should be effective. Creating evaluation models is very difficult in health technology. We can't really do clinical trials in the same way you might do for a drug, and to be honest, we probably shouldn't be. It's quite iterative the way it's developed, and also how we're going to, you know, if we have a piece of technology that's being updated and growing, how are we going to keep, if we have to keep doing clinical trials for each little update, that's not going to be feasible. And so being able to appropriately evaluate things has been really, really difficult, and is really important. And responsibility, we need to have clear lines of accountability, be that for the person creating the technology, as well as at a national or potentially even international level. So again, that there's responsibility in place for it. If something goes wrong, someone's going to own that, someone's going to do something about it. And again, this all comes back to users feeling that they can trust and engage with technology. So what do we need? Digital health strategies. We've seen a number of these already. As talked about right at the very start, the country that's doing this absolutely the best is Rwanda, and I would definitely recommend that you check out everything that's gone on there. They did a 5-year strategy until 2020, and they've now got another 5-year strategy coming out. And what they did particularly well comes into this next idea of robust regulatory frameworks. Regulation's way behind innovation in health technology, and that's going to only cause more and more problems. And what they did in Rwanda, which was fantastic, was they took people, the regulators, they took the health technology companies, the doctors, nurses, got them all together, and they created the regulatory framework as a multidisciplinary way that meant that it worked for everyone. Now, obviously, some people balk at this. They say, why would we have the companies in the room? They're only going to have their own, you know, what should we call it? What it is? Sorry, I completely lost the word. They're going to have their own needs in mind. They're not going to want to work for the people. But actually, that's not what happened, and they created something really good. Evaluation models, so we're trying lots of different ways of evaluating health technology, doing simulations and things, and also skill sharing, capacity building across regions, across nations. But most of all, yeah, what we need is collaboration, understanding how healthcare professionals and technology can work together, how augment their practice, allow them to spend more time and be better doctors. And the very last thing was just I almost left this out to talk about the role of the World Health Organization, because I think it's quite a nebulous idea, and again, it feels like it's just a bit of a repeat of before. But again, what I think the WHO's role is to provide these international standards without being too stringent, because what's going to work in one country won't work in another. And like I said, you know, we can't account for everyone's cultural context or everyone's ethics in one, you know, single health technology document. Facilitate that skill sharing, and we've already seen some of that happen already, which is great. But it'd be really great if we could start to have more countries in particular that are doing this really well, being able to go and help others that are maybe struggling or don't have quite the same expertise. Holding countries to account for upholding human rights is quite a big one. There's lots of concerns about health technology, particularly in the time of COVID, being used for increased surveillance. And certainly in the UK, there's concern that our electronic health records are being used to identify people that are not documented within the country, and also prevent inequalities of access. So again, we could talk about this for hours and hours, but what I don't want, or what lots of us don't want, is for technology to go the same way as pharmaceuticals, and all of a sudden we're going to have all these patents on technology that prevent people that need it the most from accessing it without paying a huge price. So I think that's, in my view, what the kind of the role of the World Health Organization is, and I'd really like to hear anyone else's. So I was just going to say, ask for questions, but I think Priit's going to speak first, and then we'll do that together. Sorry, I realise I've gone over a couple of minutes. I got way too excited.
Great, thank you, Lisa. That was a really comprehensive presentation that I think provided kind of a full overview of the digital health landscape, how it's changing in response to what's going on right now, and some of the challenges, particularly in this governance and regulatory space, which I think when we're talking about organisations such as WHO, that's obviously going to be a key part of any role that they will play. I'm now really happy to hand over to Priit, who is another digital health expert based in Estonia. And as Lisa's alluded to, Estonia, we invited Priit because Estonia is one of the most interesting countries in terms of digital governance anywhere in the world. You can become a digital citizen of Estonia and lots of other things. So it's a really interesting place and lots of lessons to be learned. And Priit also did work previously for the Estonian mission to the UN in Geneva, so has got a good understanding of WHO and WHO governance as well. So really looking forward to hearing what Priit has to say now. Thank you.
Yeah, okay, great. All right, so let's get started talking about, just trying to give you a bit of a country perspective on this digital transformation that has been causing quite a bit of excitement in the past years, especially with the WHO digital strategy coming out. It was supposed to come out this WHA, but I don't actually know if it was adopted or not because of all the, I don't know. Anyway, I kind of lost track of that, but the assumption was that it would be adopted. Anyway, I'm going to start off talking a bit about Estonia and not just about e-health, but also the e-state, because it's something that we stress to everyone, is that we don't suggest building an e-health system as a standalone thing. It makes sense to have an e-state that has various aspects of it digitized, be it the judiciary, your healthcare system. So in Estonia, we are 99% digital, so every public service can be done and accessed online, except for getting married or divorced or selling real estate. I recently discovered that finishing medical school also cannot be done online because you had to sign a form which for whatever reason had to be done in person. So I haven't lodged a complaint yet, but I shall. So going on to the e-health system, which ties very much into the e-state, I'm going to talk a bit about how we built this, and I'm going to tie it to three aspects. One is people, then it's principles, and finally it is the technology, and the order is very much intentional. So our e-health system started in 2008, which is when we launched the national EHR, but actually our preparations for having an e-health system started in 1992. Which all started with giving people the digital skills necessary to actually benefit from the digital transformation happening all over the world. So we made sure that there would be a computer class in every school once we achieved our independence, and ICT education is very much a part of school curricula these days. So there's a digital competence framework that you have to meet by the time you graduate high school. And it was also important to us in the early 90s, and continues to be important, that we also have these general population geared digital skills courses available. And of course, courses are also made available depending on the profession that you're in. So there are courses for medical professionals, financial professionals, what have you. And this is really important because you need to have a population actually able to benefit from all the digital services that you are putting forward, to make sure that you are not exasperating any inequalities that might already be present by digitizing. The second thing is principles, and principles are often enforced by legislation and regulation, but it's important to just decide what kind of criteria your health system has to meet, your e-health system. And there are a number of these you might have heard of, about like once only principle, and digital by design, and privacy by design, trust by design. But I think some more important ones that I would like to stress here are actually more related to patients and doctors. So a simple principles that you can word is that patients should always have access to their health data. They should always be able to control who sees and uses their data. And also doctors should be able to access it anywhere, regardless if this patient came from the south of your country or the east of your country. If they previously went to a physio, a family doctor, or an ER, this data should be made available when you need it. And once you have these principles in place, only then would I recommend actually looking at the technology that will enable you to meet those principles, because technology shouldn't be something that you do in and of itself. It should always be there to help you meet your goals. And in the Estonian case, there are free technologies that I just like to stress, because without them, we wouldn't have an e-state, we wouldn't have an e-health system. Number one is interoperable data exchange. So, you know, there's a lot of talk about how do you make data interoperable between countries or even within countries. And the way we did it is by having a single data exchange layer, which is ambivalent towards the type of data that it transfers. So we call this X-Road, which is an open source internet-based technology, which is a way to transmit whatever data across your national databases. And in the Estonian case, X-Road covers really everything from the court systems to business registries to the e-health system. So e-health is really a tiny corner of X-Road, which allows all the different databases that make up the e-health system to communicate with each other. And what we found is that by having X-Road in place, by being able to do all these queries about anywhere in the state, we save about 1,400 years annually simply by not making a person do those queries for you. You can access all these things without a person being in between. And we have about 1,000 organizations connected via X-Road, and it does about 900 million transactions per year. An important thing that we like to stress is that X-Road is not some kind of central database. It doesn't hold any data. It just helps data go where it needs to go. The only thing that X-Road holds is data about queries made, which is important for cybersecurity purposes, which I'll get into. Another thing which is very much a core building block, which I can't imagine us having an e-state or an e-health system without, is secure electronic identification. So in Estonia, we started off by everyone having these kind of ID cards. I mean, you can use them to travel if you want, but you can also use them to access whatever e-state service there is. And you need these simple ID card readers in order to make use of them. And every Estonian has an ID card by today. We've also added other functionalities. So there's also a mobile ID. So you don't even need to have that piece of plastic anymore. You can just have it in your SIM card. And Smart ID, which is web-based, which will only work if you have a mobile ID or ID card first. So this kind of identification is very important because it tells the system who you are, and based on that, what you should know and what you can do. And it also enables you to leave a mark on every piece of data that you touch. And the final technology, which is not a single technology, but which just has to be always taken into account, and which Lisa also was talking about, is cybersecurity. So digital identification is not just a way to identify yourself, it's also a cybersecurity tool to make sure that you are only privy to the data that you should be privy to. So by logging into a patient portal, you only see your own data or the data of your underage children or people who you are a caregiver of, not anyone randomly. It also means that any piece of data you touch, for example, as a doctor, will have your digital signature on it, which for one makes it very clear who actually gave this information. Is it trustworthy or not? But it also has an important thing, which is immutability, because everything essentially gets sealed. Every piece of health data gets sealed with this digital signature or stamp. And if you wanted to change that piece of data, you would effectively have to break the seal. So it's also a cybersecurity measure. Then logging, as I mentioned, X-Road keeps logs, which is very important to know who asked what of what information system at what time. So by default in the Estonian system, you're allowed as a doctor to access data about any citizen, but every query you make is logged. which means that if you are looking up a patient who you have absolutely no care relationship with, then we will always be able to trace you back to that query, and if that was an illegal query, then we will be able to enforce some sanctions on you because of that. Compare that to having everything in a folder, in a locked room somewhere in a hospital. Any janitor can access it, can look at any file. There is no trace of that happening whatsoever, but this is not possible in the Estonian system. And a lot has been talked about blockchain. For us, blockchain is very much a cybersecurity measure, making sure that the logs that we keep, which are so important for enforcing the regulations that we have, are guarded so that nobody can change the logs because they are held on a blockchain, which means they are distributed. You have to change thousands of blocks at the same time if you wanted to change the log. And finally, monitoring. Logging is only as good as the people actually looking at the log, so you need to have somebody doing that, preferably an automated system. Right, and based on these core technologies, we've gone on to develop a number of e-health solutions, which I'm not going to go into detail on. There's a nice video called An Overview of E-Health Services in Estonia, which is up on YouTube, which you can always have a look at. But I mean, the key things are the patient portal, where any patient can access their data. They can lock their data, unlock their data. They can use some services. For example, if they want to apply for sick leave, if they want to apply for a health certificate, then they can do that from the patient portal. E-prescription, it's basically your regular prescription, but instead of having to use a paper slip in between, the prescription just goes directly to every pharmacy. You don't need to go to your doctor to get that prescription slip anymore. You can just identify yourself at the pharmacy and you get your prescription. Based on that, we also added a drug interaction decision support. So at the point of prescribing, doctors get a warning if the medicine they are prescribing interacts with something that the patient is already taking. E-ambulance systems are a way for ambulances to quickly gather data about the patient before they even see them. So they already know what kind of diagnoses they have, what prescriptions they take, anything that might be relevant when going to see that patient. E-consultations are a way for family doctors to communicate with specialist doctors if they are having a complicated case, which is useful for avoiding, for example, these situations where a family doctor refers you to a specialist, you wait in line for 3 or 4 months, and only to discover that the specialist will say that, well, this is easy, this is not something you have to come to me with. So to avoid this, we allow this e-consultation to happen in between, where the specialist can first assess if this patient even needs to come to me, or if they're actually able to consult virtually and can be handled at the family doctor level. And e-booking is our one of our newest services, which is particularly useful for avoiding these very long wait times to see a specialist, because instead of having every hospital has their own e-booking system, you can now query the entire state. So for example, if you are used to only seeing a specialist in the 3 hospitals in your neighborhood, you might have a wait time there of 3 months, but if you are willing to drive 2 hours to the other side of the country, then you might have a wait time of 1 week. And I've seen this many times in my own personal experience, that it does uncover a lot of free times that you would otherwise never have found. So these are some of the services that have been quite useful for us. And the lessons learned are quite important, and I think this comes to the governance challenges that I was asked to speak of. And these 6 I tend to talk to other governments about and WHO about. So number 1 is balancing digital and health, which means that you shouldn't digitize for the sake of digitization, but you also shouldn't avoid digitization because you somehow think that digital and health do not mix together. I'm going to show you 2 very different graphs. The top graph is our electronic prescribing. So electronic prescribing took us 9 months to go from 0 to 80%. So it was a very fast uptake. And by now, every prescription is digital. The below graph is the uptake of our national EHR, which took us 6 years to even start to get going, and then an additional 2 years to start to see exponential growth in usage. And I think there's a very clear reason for this, is that the top e-prescriptions are a good balance between digital and health. you, on the one hand, you get this very nice digital data, which you can use as an administrator, which the patient can see in their patient portal. But it also saves time for the healthcare system, because doctors no longer need to hold these prescription slips. If they want to repeat a prescription, it takes them 10 seconds now, because they just take the old digital prescription and renew it. They can build services on top of this. They have the drug interaction decision support. Patients also benefit from their healthcare journey, because they don't no longer need to go to the doctor to get a prescription. They can just call the doctor in case it's a repeat prescription for enough. So there's a lot of health benefits that come from a lot of health system benefits that come from the e-prescribing, which are not just related to the administrative side of things. Whereas for national EHRs, they tend to be very good for the administrator, the people that want to have good structured data. They're good for the patient because it allows them to access their data anywhere. For doctors, at least when they began, they were a pain, because they didn't really see how they were benefiting. You know, they're used to getting paper-based records from whatever patient they see. They didn't really feel like they were getting a lot of added information. It was just something that took up their time. If you look at statistics about electronic health records, you'll find that there are like a lot of mistakes that propagate over the use of an EHR, which are just copy and pasted to the EHR. So most doctors that I've met at some point in their career hated EHRs. And that is something that really made it very hard to have good uptake on EHRs. And I think the reason is because we didn't think enough about how this is going to impact the work of doctors when we launched it. It took a lot of iterations for EHRs to become useful, for the data to actually be transformed into services that are also valid to doctors themselves and not just patients, which is why it took such a long time for EHRs to take off. Another important lesson is iteration, very much building on what I just mentioned, in that you're never going to get it right the first time. In the digital sphere, it's very common these days to move forward in sprints. So you make one feature, you get feedback, you change, you make another feature, get feedback, change. This is not how we used to build things 10 years ago in the eHealth system. We just tended to bring everyone together, ask everyone, so what do you want? And then the IT guys locked themselves in a room for 4 months and came back with a finished product, and then nobody liked it. So these days, we are far more iterative when it comes to launching government e-services, and we try to have as much active communication as possible with the actual professionals and the patients using these services in the process of rolling them out. It is a multi-stakeholder process. You do need to not just not have your e-health team on board. You need to have your whole ministry, your whole government on board, and ideally also the doctors, the companies, as Lisa was talking in the example of Rwanda. So, and when I first put this down, actually the lesson that I wanted to put forward is that e-health systems should not be separate from health systems. We had an e-health strategy from 2015 to 2020, which was very much developed by the e-health people. It was a multi-stakeholder process, yes, but it didn't have the kind of buy-in from the health people that that we would have liked back then, and this led to some problems down the road. These days, we're moving away from having a separate e-health strategy, a separate e-health team, and we're trying to integrate them as much as possible. So moving forward, we're just going to have a health strategy, and within these health goals that the government wants to achieve, we have e-health solutions that help them achieve that, which I think is a healthier way to move forward as a kind of a whole of ministry approach. But it also, this fact that e-health is a multi-stakeholder process also stresses the importance of leadership and governance. If it's too distributed, if you give too much freedom at the level of the hospital, at the level of the company, then people are going to get frustrated eventually. It's like, why aren't you enforcing enough standards? Why aren't you making decisions? And we were somewhat reluctant as a country that loves its distributed systems to make these hard choices, we allowed hospitals to develop their own health information systems, and et cetera, et cetera. But these days we do see it very important that there is a single leader to this process. Even though you can give a lot of responsibility to the hospital level, having a single leader that puts forward the strategic direction and makes the tough decision is always going to be important. And I feel that the people that we used to give quite a bit of freedom to actually appreciate that, because it does help them avoid getting into lots of the fights that they currently get into. And it takes more, of course, than just the health system. It is an ecosystem that goes into the e-health system. And particularly, it is the companies that build e-health solutions. We have never considered the government to be a software provider. We consider ourselves to be a standards provider, a maintainer of the central infrastructure. But when it comes to actual, patient-driven services, we are quite happy to let companies lead the way, because they tend to be quite closer to their own specific stakeholder group. And it's sometimes hard, because as governments we tend to feel that we should build everything ourselves, everything is centralized, et cetera, but it's actually sometimes better to have a look at the innovation that is happening out there on the entrepreneurial level, and to maybe co-opt that, to maybe take that on board and make that a national service with that company as the provider. But of course, that also means that you have to have good regulations in place to avoid some of the pitfalls of PPPs. But I do think it's very important, and our experience has shown that you do need to work with the companies and not against the companies, to avoid a waste of resources and to get the best of the experience of both sides. And finally, a point which is not so general as the others, but which I feel is often overlooked, and was definitely overlooked in our case, is to think already about the secondary use of health data. So, we just wanted to get going with our EHR. So we just, we had a lot of free text when we started off our national EHR. Doctors just write down notes. They're used to that. But nowadays, when everyone's talking about how useful data is, particularly in the face of COVID, to make decisions, that can sometimes be damaging. Anything that is in free form is very hard to reuse. So think in advance about how much you can, structure as much as possible. Think of ways to capture that data in a way that it is structured, but at the same time doesn't add a huge amount of work to the doctors that have to capture it. And do this early to avoid this mountain of unusable data, which you will gather if everything is just in free form. And finally, I'm just going to finish here. I'm a bit over time. Is the international perspective, and when it comes to what could be the role of the WHO in e-health, I tend to first think of the experience that we've had at EU level at the e-health network. So e-health network is something that has been launched in 2011. All the EU member states are a part of that, and we come together to make strategic decisions about cross-border interoperability and use of health data for research. And also we do experience exchange, learning from each other, and sometimes we co-create. For example, we just created this patient empowerment framework that utilizes digital health for the sake of patients. And we did that within the mandate of the e-health network, with all member states contributing. And what's one thing that the e-health network has achieved is a level of interoperability within the EU. So Estonia and Finland were the first to launch cross-border digital prescriptions in early 2019. There's also a patient summary block which has been exchanged by a number of countries, and that Estonia is also in the process of implementing. We're moving towards lab results, image descriptions, EHRs in total. And there's been a lot of work to develop these data objects, the standards that go into that. And this is something that could easily be happening at the level of WHO too, because the EU is just 27 countries, whereas in the WHO is 192. So this kind of central organization for making strategic decisions, deciding on standards, exchanging experiences can also exist within WHO, but at the same time, WHO needs to be very mindful that they are not alone here. There are international organizations already working on this, HL7, SNOMED, IHE, and WHO should be very mindful of this, that they are not entering a vacuum, they're entering a space that has been populated for decades. So finding that added value is going to be tough, but there is definitely space for international collaboration, moving beyond the structures that already exist. But I think the EU experience has been very informative how this can be done, and I do hope that that there's going to be a continued collaboration between us here at the EU and then the broader WHO digital health strategy. Okay, I'm finishing here.
Brilliant. Thank you, Priit. That was really interesting. And I think it was really cool to hear about Estonia's transformation, both in the kind of wider digital space as a state, and then how that applies to health specifically, and thinking through what kind of principles need to underpin this, and a bit of your experience of what the role of the state versus the role of the private sector and others and citizens in all of this. So thank you very much. I really enjoyed that. We now have about 10 to 15 minutes for questions to both Lisa and Priit. So I hope people are not feeling shy and are going to go ahead and ask lots of questions to them. If anyone has anything in particular they want to do, you can either put it in the chat box, or you can raise your hand and we will allow you to unmute yourself. So feel free to ask away. Oh, thank you, Priit, for kindly agreeing to share your slides as well. Does anyone have anything in particular that they wanted to ask straight away? Yasin?
So both of you touched a bit upon this, but what are your thoughts in the very specific context right now with respect to contact tracing apps and a centralized model versus a decentralized model of how the data is stored and shared? That's it. But I think that the practical issues and maybe the social acceptability in the different contexts where you are.
Well, I can start off here because I've been a part of this debate happening in the EU for weeks now. As I don't come from a privacy background myself, I am in a sense open to both models, but it has to be, the choice has to be mindful of what is your patient willing to basically have. So what we learned in the Estonian system, we did quite a bit of surveys about what are your major concerns about these contact tracing apps, and you know, far and beyond, the number one concern was that there's going to be some kind of government tracking of people going on when we do these contact tracing models. And that is very much what drove us towards a decentralized model, to take away the capacity for a government to do this. Because even if you do it in a very privacy preserving manner, a centralized model will still at the very least allow you to build a social graph, which does give you some data about people that you perhaps don't have business having data about. This can be quite minimal, but at the same time, there are a lot of concerns right now out there about governments perhaps overstepping their mandate, using too much data on their patients. So that's why we had a decision to be decentralized, just take that capacity fully out of our hands to drive up uptake, because uptake is going to be important if we want to make use of these contact tracing apps. You can't make them mandatory, so you have to make them attractive to your citizens, and that's why we chose decentralized. There are some centralized models, protocols, which apparently would also allow you to remove that capacity from the government, but they're very theoretical and they're not implementation ready. So most centralized models like OpenTrace will always have some capacity to build that social graph on the government level.
I mean, I don't think I have a huge amount to add in the sense of one versus the other. I completely agree with everything Priit just said, and I think definitely the concern, certainly here in the UK and in the US, and I'm sure in other countries that I just don't know in enough detail, is this idea that we now have these massive companies, some of whom are usually doing national surveillance or national security work, now accessing potentially these huge centralized databases that are going to come up these contact tracing apps. And I think it's not only just for me about like uptake, which I think is the biggest driver for lots of reasons towards a decentralized model, but also the idea that we can't rely too much on these apps, because what, you know, we're theorizing out how they're going to work, and I was doing the risk assessments, one of them here in the UK, is this idea that people aren't going to self-report if there isn't a way for them to test and get like a result back quickly. And people, don't want to be stigmatized if their friends, think that they've given them COVID and that's impacted them negatively. So actually, I think really the question with these contact tracing apps is what the public policy space is going to be around them. Again, I think India a few weeks ago have said that employers have to enforce, this on their employees to show that they've downloaded and they're using it, and that kind of takes away any choice architecture and that we had, or any sort of arguably free will that we had around using them. So for me, just to build on what Priit said, that's actually the biggest ethical question at the minute, rather than what the app itself will look like.
Great, thank you. So we've got a question from the chat box, and I think that's directed specifically to you, Priit, from Okoth. So what blockchain platform have you used in Estonia? Why those particular protocols? And then you mentioned public-private partnerships. How's that coming along on the business end and for the private sector, and how are the different entities synced? So if you want to have a go at.
So Estonia uses a type of blockchain called KSI blockchain, which was developed in Estonia by a company called Guardtime. Why particularly that one? Well, that's a good question. I'm sure there are other KSI blockchain providers, but I think the key choice that we had to make was between fully public blockchain and private blockchain. Basically, either having a permissionless system or a system with a trusted entity. And because our e-state does contain a trusted entity, we chose a private blockchain system, not to mention that this is far more energy efficient than the public systems like your Bitcoins, for example. But for private-public partnerships, there is not a lot of true innovative models for PPPs in Estonia, so most of them are quite safe. It's very much done within the government framework, so the government actually commissions companies to do things for them. So very rarely do we have a private company building something for the e-state outside of a tender model. But the way that we keep ourselves in sync is by having a lot of interaction. That's one of my jobs is to be very much in line with what is happening on the market, to talk to these companies, to understand what they're providing, to give them updates about what the government is building. Because what we want to avoid is that there is, for example, a company building a useful service for, I don't know, 8 months, and they're ready to deploy, and then out of nowhere, the government rolls out this service. Because that is wasted work on both sides. It's not always that the government service works better, and it's not always that the private company would not be willing to actually work with the government to roll out their service. So we try to sync our plans as much as possible to be clear about what are the things that we think only a government can do, and what are the things that we believe a private company can provide within a government framework. So having this ongoing discussion is very important. And I guess one thing that we are now doing, which will open us up to better use the market a bit, is that we are building a consent system within to the national e-health system. So if you as a patient want a company, for example, to use your health data to provide you a digital service, you are able to do that by giving consent to them using your data. But this is still in the process of doing an impact assessment and trying to understand what are some of the pitfalls of doing this. But it is a strategic direction we've taken because we're very mindful of the fact that there is so much you can do with health data. A government alone will never be able to do all the useful things that can be done there.
I guess I'm going to use the chair's prerogative. Lisa, I guess you've probably got, knowing you, lots of thoughts on the sort of public-private partnership model in the digital health space. And I guess, I think particularly thinking of what's the issues around the app in the UK and the public discussions around conflict of interest and particularly in the sort of procurement. And I know the UK, for everything COVID related, has gone away from the normal tendering open competition model. So what your thoughts are on public-private partnerships, and perhaps also if you had any thoughts on countries that are not as strong in terms of state institutions to regulate that as well.
I mean, I'd argue, first of all, thinking of your last question, that no one's got a strong enough regulator for this kind of stuff. We're just not doing it very well, or that often technology regulation, because understandably, you know, maybe when it first needed to be done, it was being done under, you know, other bodies. It was kind of absorbed into them, and actually people aren't always very good at creating their own independent regulator. So even within the, so I'll use the UK context is what I know best, and I don't want to misspeak about anyone else's national context, but you know, we have our own medical health regulatory agency. Yeah, that's great. And we have within that within our medical products, we're including health technology within that, and we've got these kind of subdivisions that are growing and subdividing even further. And we're sort of saying, well, at what point do we need to bring this under a different technology regulator? Same with social media, it's under this kind of information commissioner's bubble, and no one's really doing regulation very, very well. And I think it's quite an interesting one, and this maybe comes back to some of the stuff about what WHO should be doing, is this idea of, well, who should be regulating it, and how do we actually have proper multidisciplinary regulation? Again, some of what Priit was talking about. And we can't just, you know, I understand why people maybe want to say this should be up to doctors and patients, and I have lots of respect for that view, but I think that sometimes what we're doing is we're shutting tech people out of creating that regulation, and it means that they don't understand it, they don't know how to apply it, or it's not done in the right way, and for good or bad, they're able to get around it. And linking in that with some of this public-private partnership, we have actually I'd say a really bad tendering process in the UK, because it's so stringent and so rigid, and it can be quite complex. And actually what that tendering process often leads to is big companies are much better able to tender in for something, and they have obviously got the finance behind them that shows that they're able to back themselves, and that can be quite problematic. And again, you find people just start to try and subvert it. My concern about, I understand in some ways why we maybe can't do things in the way we used to during COVID. As much as I will talk lots of bad things about this Palantir deal that I was mentioning earlier, which is giving them lots of access to the NHS data, they also are very, very good data analysts, right? Like, they've got huge capacity, huge capability, and they're going to be able to do things with that data that could be immeasurably helpful to the COVID response. No one's denying that. I think it's working out when that stops and how we disentangle it later, and what they're able to keep, and how long they're going to keep it for, and what we're even counting as health data. It all just becomes so messy. And I think until we start to answer these kind of big questions, be that on a national level or an international level, that then allow people to try and apply them to their own context, as well as understand we're just not going to get it right in the first place, and there probably will be more data breaches, there probably will be more things that are going wrong. But I think my biggest concern is that we're going to just start seeing more and more of a data market. So, you know, let's say a UK hospital sells lots of data, they get loads of money for it, something amazing is created, but then it's all of a sudden really expensive, and no one else in the country, or indeed in other countries, will be able to access it. Yeah. Great. Sorry, that was quite a convoluted answer.
So we've got time for a couple more questions. So we've got one from Pablo, specifically for Priit. How applicable is it to implement an e-health system in a low and middle income country, and considering that health systems already have a lack of resources and limited technological extension? And I think Lisa, you can also come in on that, because I know you've worked with a few development entities. So Priit, do you want to?
Yeah, I never really do consider e-health systems to be necessarily hugely expensive. That, of course, depends how you build them. But in Estonia's case, I mean, we started digitizing in 1992. We had just come out of 40 years of Soviet rule. We were not a rich country. We were very much a lower middle income country when we started doing that. And we just started looking for very cheap solutions on how to solve this. So, I mean, the things that you always have to take into consideration is, what is the actual internet penetration? What are the digital skills of your population? How many people will you leave out by developing the service? I think this always has to be taken into account in a lower middle income country. But I don't think nothing actually excludes you necessarily from building an e-health system. Just depends on how you build it. I mean, the whole budget for the national EHR in Estonia was below. I will mistake it, but I mean the whole budget was far lower than what I've seen in other countries, and I think it can be done in a low and middle income country. And with the penetration of mobile internet, I think more and more people will actually be able to access online health data moving forward. And I've always been quite inspired by the work that is done by Aravind Eye Clinic in India, which goes to very underserved population and offers telehealth services to them to fight blindness. So I think that there is a scope to build e-health systems in any income country, and in the Estonian e-governance academy, we definitely have a lot of very small countries that are working with us from the Caribbean and from Africa. So I don't think necessarily they are excluded, but I think this is, again, since I've not worked with any of these countries, this is better suited for Lisa to actually comment on.
I mean, I think I would completely agree. I understand the concern about cost, absolutely. And I think obviously it's everything within that system. Like, it's very easy to say, well, we can get you this software and this many, computers and things. It's also this idea of the kind of cultural cost and what it sort of takes to ensure that a technology, particularly one that's not created in that region or within that culture, is going to apply and integrate in the same way. Like within the human factors, we can't just be thinking about this as technology just purely standing alone, and how people work with it is very important. I think the most exciting things that I'm certainly seeing in e-health are coming out of low and middle income countries. Like, genuinely, people are leveraging technology in incredible ways to actually address health inequalities. Like Priit was saying, bringing telemedicine to people, and they're using artificial intelligence to look at radiology images in countries that don't have that many radiologists. Lots of workforce issues being addressed in that way, and I think what's quite interesting in not all low-middle countries, absolutely not saying that, but without going into depth any one in particular, I think that a number of countries are in a position of transforming their healthcare system. They've maybe had other things going on, be it conflict or climate issues, that have meant that they're having to rebuild some of these systems, and actually getting the support to be able to do e-health the right way from the get-go means that they don't have these kind of old creaking institutions like we have in the NHS that you're now trying to force e-health into. And genuinely, I think a lot of low-middle income countries are the ones who are the most agile, the most adaptive, and really, really driving all this forward.
I mean, when I look at X-Road, which has an international community of implementers, I mean, this countries all across the board. I mean, you have countries like Estonia and Japan, but you also have Vietnam, Cambodia, Madagascar. So these technologies necessarily are not exclusive of your income bracket.
Okay, and I think, so have we got any more questions? Thanks, Pablo, for that question, and thanks for those great answers. Do we have any more questions people want to ask? Oh, Flora here. So how, and I was actually kind of thinking of whether I was going to use my chair's prerogative to ask a similar question to both of you. How to ensure access for those with less digital skills, older people, the homeless, those who are cut out and marginalized by society? Is there national data on inequalities caused by the digitalization in the healthcare sector? I think that's specifically looking at Estonia, but it'd be interesting if there was data for the UK. What kind of support for the population was necessary to implement digitalization? So I'll throw that open to both of you.
I'll go real quick. So I think there definitely is data for the UK and for a number of countries. I wouldn't know it off the top of my head, but I think, as I said earlier, there's lots of links between particularly older age and sort of lower education status and what that means, as well as certainly I do a lot of work with migrant refugee populations here in the UK, and again, they're classically much more likely to be digitally excluded. I mean, I think sort of the support for the population, one thing that was debated in the most recent election in the UK is this idea of having national access to good internet, so having sort of free broadband for all. It sounds like a very lofty goal, but actually that's not a very difficult thing to implement. There's a number of countries that actually have very good free Wi-Fi literally everywhere you go. So putting in that kind of infrastructure and having that is a big step, because there's a lot of people that are paying or unable to afford to pay for internet subscription all over the world, not just in what people consider classical low income countries. And I think the skills is a really difficult thing. I think we have to accept that some people won't want to gain those skills. People, particularly older people, it's just not of interest to them, and they have to kind of at some point say that's fine, but then say, well, you can't just be excluded because you don't have those skills, and what are we going to do to bridge, rather than make you bridge back towards us. Again, I don't have a really good answer for this, but I know there's a lot of really good community initiatives here in the UK that are really working to try and upskill people, and upskill people that have maybe just more recently come to the UK, as well as people that have been marginalised in other ways, and actually using technology as a way to bring them back and reintegrate them, which is also like a really nice angle to put on it, rather than putting the onus on them and saying that they don't have the skills. It's saying, well, we're not looking after you in the right way.
Right. This question has come up a lot more in recent years, and I've had some researchers come to me looking into the health equity of digital solutions, and I actually don't have data on this from Estonia, because we haven't done health equity impact assessments to digital health services, and perhaps this is something that we need to do more of moving forward. I think the general evaluatory framework for digital health services has been a bit lacking in most countries, and that we tend to look at very basic cost efficiency, but not looking at the broader picture of which equity is one aspect. So Global Digital Health Partnership, which is currently working on assessment criteria for digital health systems, has actually also pointed this out, that the health equity assessment does need to be a part of it. But I mean, that doesn't mean that we are not mindful of the fact. And you just need to consider your population and what this new service demands of them. You know, if we didn't have 100% penetration for the national ID card, then it would be very unfair of us to, you know, make any services that demand using that. So, you know, from the get-go, you shouldn't demand some kind of expensive piece of technology to be able to access a digital health service. Doesn't necessarily mean that you can't use this expensive piece of technology, but it does mean that you need a fallback option for those that can't afford this. And what we've tried to do from the perspective of the patient is to build our e-health services in a way that you don't necessarily need to have digital skills to use them. I've been asked, how does a grandma use e-prescription? Well, they use it like a normal prescription. They don't need to log in anywhere. They don't need to even have an internet connection to use this. They just need to have a personal identifier, as they need for anything, and they go to a pharmacy and identify themselves. Everything else happens in the background. The state does it for you. So trying to keep this in mind as much as possible when rolling out your core services is a way definitely to fight exacerbating some kind of inequalities with your digital services, because nobody by default is left behind by implementing them. Nobody needs to have digital skills to get an e-consultation, to get a drug interaction decision support used on them. Indeed, some of the technologies might actually help fight against inequality, especially for people living in remote areas. If you implement a telehealth service, then that saves them a lot of economically useful time that they would normally have to spend commuting to a higher care center, if they can just do this via a remote consultation. So yeah, whilst there isn't a lot of hard data that I've seen, I think there are ways that you can develop e-health services that they don't exacerbate inequalities. You just have to be careful when doing it.
Okay, and I'm going to take one final question. So we've got a question from Armet, and this is an interesting question around how you evaluate and measure the effectiveness of digital health services. So what validated tools are there that might help to effectively compare between a digital health service versus a conventional service? Are there any particular tools or evaluation frameworks that you can share with us and talk about for kind of evaluating digital health services as opposed to a more traditional conventional healthcare service? And if you also want to say a few remarks just to wrap up this session and anything else that's come to your mind throughout this discussion, that would be great. So either of you want to go first?
So when it comes to assessment frameworks, I definitely would recommend two areas. So one, Global Digital Health Partnership does have an evaluation work stream, which is putting forth a lot of interesting research on what kind of aspects actually need to be looked into when assessing an e-health service. And another thing which we are currently in the process of implementing, and which Lisa will surely know about, is that there is a NICE framework for digital health technologies, which looks at a lot of different aspects of this digital service and technology that you're implementing. And we are we originally started adopting this nice framework to better understand and better evaluate some of the technologies coming in from the private sector. But as we move on and as we use it more, we're actually thinking that, well, hold on, if we are holding our private sector to these standards, we should also hold ourselves to these standards. So I definitely recommend having a look at the NICE assessment framework. I think it's very well thought out, the way it's done in a tiered level, so that something that is rather basic doesn't have to go through this rigorous randomized controlled trial, but something that might make a medical decision for you ideally would. So I think this is it's a good framework worth looking into.
Thanks, Priit. The only one I actually know very well is as Priit was saying, here in the UK, we have the National Institute for Clinical Excellence. I've linked to their the page to their standards. These are digital health standards that we in Public Health England, along with some other partners, created and have been iterating on over the last 18 months or so. And the sort of next step of those that will come that people should definitely keep an eye out for is looking at ways to actually implement them. So yes, we can have these evidence standards, but how do people actually show that they meet them? Because like I was saying much earlier, we can't sort of do randomized control trials in our traditional studies. We're coming up with new ways of building evidence, as well as also the cost-effective models behind this. Now, we obviously have done cost-effective models. There's lots going on, and we're developing these further and trying to bring in things like, for example, it's very easy to say like how one service compares to another, but what are the other caveats we need to be putting into the digital service, for example, to address things like digital exclusion. As for final remarks, it sounds super cheesy, but there was a quote that there's a guy called the Medical Futurist who puts out like quite good weekly or so newsletters that sort of up to date on what's going on in health technology in a very accessible way, so I'd recommend them. But he spoke at the AMI conference a couple of years ago, and there was a really great quote he used. I don't actually think it was his, but it basically said that AI won't replace clinicians, but clinicians that use it will replace clinicians that don't. And I think that was just quite a nice one for me, because people often think of, oh, this technology is going to disrupt, me being a doctor, it's going to stop me being a doctor, it's taking away the vocation that I have. But actually, I think for me, it's much more about how people work together and use it to augment, to be better doctors, have stronger health systems. So yeah, that was the final thought to leave you with.
Brilliant. So thank you both. That was really excellent presentations, and I think a really interesting Q&A there with some really interesting points brought up, and I really appreciate that the people that have put forward questions. Lisa and Priit have very generously agreed to share their slides, so we will send that out alongside the recording for those who, due to time zones, because I know this is silly o'clock for some of you, and couldn't stay for the whole thing. So we will make all of that available, and we'll make sure that we pop the links in a final sum up, wrap up thing.